people who are lower income, people who are from underrepresented minority groups do worse.
My very basic understanding of econ.
It's like, oh, we think 90 cents is the right number. Like the UK, for example, that have a single payer system that's run by the government.
A ton of money that we're giving to hospitals is going towards supporting those people in the back room. Like,
It's not as bad as it used to be, but
here, make me more money. Is that kind of, it's like an investment firm?
I had the almost identical situation, except I didn't have to be helicoptered out. But
what, I guess, qualifies as an emergency, right? Thank you, Dr. Roby, for coming on to the podcast. So can you tell us what your expertise is and like what your concentration is and stuff?
Sure. So my training is in public policy, but I ended up specializing in healthcare. And so throughout my career, I've kind of focused on health insurance coverage, access to care once somebody has health insurance. And I do a lot of work on kind of Medicaid and state programs. And then that led to me doing a little bit more work on health equity issues. So when certain populations aren't benefiting from health insurance as others might, and also how different types of safety net providers, which are the name we use for talking about community health centers, public hospitals, deal with their patient population and kind of redesign care to address more vulnerable groups.
Okay. So like what you said that there's like this disparity, like this equity issue that we have. Would that be an issue between the coverage and like who's able to use it? What populations are being disadvantaged by stuff like that?
I mean, I think there are many different equity problems in our system, ranging from racial ethnic inequities we see to disability-based inequities to language-based inequity. So generally, immigrants, people with lower English proficiency, people who are lower income, people who are from underrepresented minority groups do worse in our healthcare system than their white, citizen, higher income counterparts who often have better insurance coverage, live in areas that have access to healthier foods, have better access to, high cost academic medical centers that their health insurance pays for. So it's a very it's an issue that we need to disentangle to an extent to really understand. And so now you've seen this move, especially here in California. We're under something called a Medicaid waiver right now called CalAIM, which is designed to improve care and social need assessment and plug people into the resources they need through their Medi-Cal plans. So here in California, if you're in Medicaid, which is the program for lower income Californians, you're assigned a managed care plan depending on where you live. And so you could get assigned to a multitude of different health plans. And that health plan now, according to state law, is supposed to do social needs screening for everyone and then figure out how to support that person. So we're seeing this more like holistic approach to addressing social needs through social programs rather than just treating everything in the healthcare system as a symptom. So we're spending healthcare money on housing instead of dealing with, an unhoused patient coming into the ER with a gangrenous foot from their diabetes and then spending a lot of money on that problem.
Okay. So it's more addressing the issues at the source than...
Yes, that is the hope. But, in our system, like federal government hands down money, state government uses it. It's all about implementation. And then now we're at the level where the actual Medi-Cal plans doing business in different areas have to, run the program as they see fit and try to address those needs. And so we'll probably see diffuse kind of outcomes across the state, depending on rural urban status, pollution, different disasters that might happen, disease rates. So there's, our system isn't simple. And so we kind of have to figure out if we're doing things at the ground level to address people's needs, we also need to make things run at the right level from a central perspective in terms of the resources available and making it easy for people to navigate.
Yeah, because I can see why that'd be an issue. At least my very basic understanding of econ is that like a government can give you a certain amount of money and they say use it on this. There's some like discretionary funding, but most of it is saying use it on healthcare. And so I can see it being tricky is like, well, we have this patient coming in with a gangrenous foot. They have diabetes. They also don't have a house. So it's exacerbating all these symptoms. How can we use this healthcare money for his housing and justify that as healthcare, right, to the government? Is there like any huge roadblocks there or?
Yeah, so there have been roadblocks. And if you look back 10 to 15 years, whenever a state proposed a housing program as part of their Medicaid program, like through a federal waiver, which is a way of asking for like a demonstration program to run in your Medicaid program through the federal government, because the federal government funds more than half of our Medicaid program in any state. the state would often ask for housing or other social needs to be addressed by Medicaid, and they would be asking for matching funds for that funding. Um, the federal government typically said no and said, like, we don't think this is healthcare. That's an issue for
Mhm.
public housing or what have you. And then evidence is kind of mounted over the years where it is very clear that people who have housing instability are more likely to end up spending lots of money on healthcare if they have an exacerbation of some chronic disease. So now there's more of a push to include housing and other social needs and act as this coordinating role. So I think that's good news broadly, but it does require this special permission that states get from the federal government to spend that money in a certain way and
Mhm.
then get the federal funds matched that they spend on it. So if you think about how it might work, is if the county has a housing program and 20% of the people in that housing program are on Medicaid, they might point to that money and say, this is funded by local property tax dollars. So we're going to show the federal government this 20% of our constituents are in housing and they cost X amount of money. And so then they're asking for a waiver from the federal government as part of these demonstration programs to get 50% of the money from the federal government to support that county program because it's a non-federal program. So there are all
Mhm.
these rules around how the matching formula works, but at its core is Medicaid, which is our program for lower income people, is a state federal partnership. And so depending on what state you're in, the median income determines your matching rate. So in California, the matching rate is 50%. In Arkansas, I think it's around 73% because they're a
Mm.
lower median income state. And so for every dollar that California spends on their Medicaid population, they're supposed to get about a dollar back, a dollar back. So they are 50 cents back so that they're able to like run the program as they see fit. So the budget is built on a federal share flowing down through the federal budget. And they need permission to do different things that violate or aren't compliant with existing Medicaid statute.
Hmm. So how do you said with the median income, that's
Mhm.
how the return rate is
Mhm.
established. Why is the median income used as a determining factor for like, oh, California gets 50, Arkansas gets 73?
An accident of history, probably,
Okay.
based on like when they came up with the matching formula in 1965, because Medicaid passed in the same year as Medicare,
Mhm.
and same bill. Um, they just determined like we want to reimburse states with more resources at a lower rate than states with higher resources. And if you think about the Southern Democrats who were an impediment to Medicare and Medicaid passing in the 50s and 60s, um, they probably were fairly active in advocating for bigger amounts coming down to their state. And they held a lot of the negotiating chips at that time. Um, there's a really good book called The Politics of Medicare by Ted Marmer, who is like a political scientist that tells the whole story about like Medicare's passage and how the Medicaid program was actually created in 1961 or so. But it was an optional program that states could adopt, and there was a very low matching rate. And so almost no states did it. All the lower income states sat it out, and the higher income states did it because they could afford to do it. And so I think it was a way of making sure that the southern states and the states that couldn't afford to create the program on their own would have the resources to do it.
Mhm.
And over the years, you saw states eventually expand the original Medicaid program. So I think the last state was Arizona in 1981 adopting, and then you see that kind of play out now in with the Affordable Care Act, where Medicaid expansion to childless adults was part of it. That matching rate was calculated at 100% for the first 3 years, and then now it's 90%. And that deal to make it 100% funded for the first 3 years was driven partially by Louisiana and Nebraska, who had fairly um, moderate Democratic senators in power at the time. Ben Nelson and Mary Landrieu, who pushed for enhanced funding in their state to ensure that they would participate. And they kind of use that as a bargaining chip to say, like, if the matching rate is the same as the original Medicaid program, we're not going to be able to afford to do it. So I'm not going to vote for this bill unless there's a better matching rate. And originally, they basically got a deal for those two states. So they called it the Cornhusker Compromise and I think the Louisiana Purchase, where only Louisiana and Nebraska had 100% matching. and the other states just had their regular matching rate.
Mhm.
And then when the bill was hammered out in at the last minute through in the House and Senate, they ended up changing it. So it was 100% temporarily for the first 3 years, and then it went down to 95% and then 90%. So the deal is actually better for the ACA population, where states are getting 90 cents on the dollar for every dollar they spend, versus your existing Medicaid population dating back to 1965, where it's based on median income.
Mm. Okay, that's really interesting.
So
Okay.
a lot of times policy decisions aren't driven by any sort of like evidence, like, oh, we think 90 cents is the right number or
Mhm.
something. It's more like a compromise made due to politics. So it's really difficult to extract politics from policy. So a lot of times when I have, I run an MPH program in health systems and policy, and I've been at several MPH programs with policy tracks, and students kind of walk in the door thinking, I'm going to learn how to write good policy. But that's a bit of a fallacy in that, like, you're writing policy that addresses the politics of the day.
Mhm.
So you're trying to get as far as you can based on evidence, but at a certain point, it's going to tip to who's going to vote for this bill or who's not. And then it's all about influence and trying to develop some compromise that'll let it move forward.
Right, because even if you say we ran this like microeconomic model, we did this very sophisticated analysis, and we found out that 90 cents is the perfect number. Some states going to be like, no, it isn't,
Right.
or
Exactly.
the federal government's going to be like, no, it isn't. So you kind of, like you said, hammer it out. You got to brawl in Congress and
Mhm.
see what number they can get to and actually agree upon. It's
Right.
interesting.
Yeah, exactly.
So this model that we have in the United States, what, I guess if you could put a name to it, what is the name of it, and like, I guess, how does it work generally? How does the money work generally?
Right. So our health system, I would say, is kind of our health system is multi-payer, which I think is a core thing to think about when you compare it to other international settings where you might have a single payer. So a big debate is always like, should we have single payer healthcare in the US versus multi-payer? And there are international settings that have multi-payer systems, but they're tightly regulated by the federal government in a way that makes it so the multi-payer sources are more comparable. Whereas we have a multi-payer kind of market-driven system. So if you think about it, we have Medicaid, which is a federal state program. We have Medicare, which is a federal program for older people. Medicaid, of course, is for lower income. Then we have private insurance, some of which is subsidized through the federal government for people to use tax credits to buy coverage. Other is bought on the open market. They're both regulated in the same way. And then there's the largest is employer-based insurance, where people are getting offered health insurance through private companies through their job. And each of those sources pays differently, costs a different amount of money, is different in terms of eligibility and how you navigate. And so it doesn't just mean that there are 5 or 6 different sources of payment. It means that people are treated differently depending on which program they're in, because their benefits are different. The price that the physicians and hospitals are getting paid within that system are different. So we end up with a very odd patchwork that results in about 7 to 8% of people being uninsured at any given time. So we have a lot more gaps on the like single payer kind of nationalized health insurance side. There are some countries like the UK, for example, that have a single payer system that's run by the government. And so physicians are employees of the federal government. The clinics are owned by the federal government. The hospitals are owned by the federal government. That's kind of the furthest extreme on the single payer side. Most other European countries and OECD countries are either single payer or they are administered by a single entity in a way. So Canada is considered single payer, and each province is the payer. So each province is making decisions. So it's kind of like if we had 50 states all delivering a different health insurance benefit, but having tight control over what the prices would be, who the physicians were, what the hospitals got paid, what the benefits were, et cetera. So it's, I would say we often are given this false dichotomy around like, oh, if we weren't multi-payer and market driven, we would be single payer like the UK. And that's probably not the case. We would probably end up with some sort of compromise model that's driven partially by market forces, where my guess is physicians, hospitals, pharmaceutical companies, all those things would still be independent and would be private, but they would probably be subject to price controls set by a federal or state government, so that they weren't allowed to charge based on negotiation in the market. They would be put on a fee schedule. So right now, if you look at a physician, let's say, um, who might accept every single type of insurance, they might charge the Medicare patient $80 for a visit. They would get paid by Medicaid $60 for that visit. They would get paid by Blue Cross $150 for that visit, and they might get paid by Blue Shield $130 for the visit. The Blue Shield and Blue Cross prices would have been driven by negotiation around a contract. And so if I'm a patient walking in the doors, that's why they can't tell me, oh, how much is this visit necessarily going to cost? Because somebody in the back office is dealing with the billing, the contracting, negotiation. They don't know if I've hit my deductible, all those things. And that's very difficult to navigate. But we would probably still have some of that in any sort of centralized system, unless we moved all the way to like the UK model, just because even if we set prices, depending on how things worked, insurance companies might have different benefits. They might have different deductibles or co-payments and things like that. So there are lots of efforts to try to create some sort of unified system. And there's actually a bill that was passed in California last year, I think SB 770, that creates this focus on trying to figure out how to do unified financing, which is kind of a name for a single payer in a way. But the option is it could be administered through the state government. It could be administered by different health plans, operating under more strict rules. So there's a lot of debate over like what a reformed health system might look like if you were to move away from this like market-driven multi-payer system to a more regulated, kind of privatized, but kind of government, tight government oversight type of model, because it would probably make things more evened out in terms of what patients got access to, the prices they were paying, the coverage they had access to. But there would still be issues that like you couldn't disentangle around health equity that aren't solved by, fixing the health insurance side of things.
Okay. So I have heard a lot, and I've heard a lot of concerns that a ton of money that we're giving to hospitals is going towards supporting those people in the back room. Like you said, those people that are working with insurance. I've heard that doctors have to work with insurance too, which is like a little bit weird because, you expect doctors to be in and out of patients' rooms, like working with people. And hearing that a doctor is spending a lot of his time on insurance is pretty scary because he's not doing his job. Like he's not doing what we think is his job. So is there like valid concerns to that, or is that like kind of a myth?
I mean, no, I think there are valid concerns around kind of the administrative costs in our system. There's not a perfect answer because even in the UK, for example, there are lots of administrative costs, but they are borne by the government and taxpayer dollars directly. Whereas we kind of devolve it down to different people in the model. So if I'm Medicare, which is run by the Center for Medicare and Medicaid Services, CMS, they basically hire insurance companies to run and administer all of the claims in a given year. So they're paying Anthem Blue Cross to run all the claims that are coming through Medicare, and they give them a cut of that money. So the administrative costs in Medicare are really low on the fee-for-service, like Part A and B side, which is our traditional Medicare, because they're basically just saying, hey, insurance company, you process all these claims. We're going to be the bank. We'll pay all the claims once you process them, and you get to keep 2.5%. And by statute, Medicare can't spend more than 3% on overhead. But then you end up with problems of overuse. There's more fraud in Medicare because like it's not as controlled, right? Medicare is just saying, these are the things in our benefit. These are the prices we will pay. Process those claims. Whereas if we look at private insurance, if I'm signing up for Blue Cross through my employer, then they are required to spend at least 85 cents of that every dollar that I spend on premiums on my healthcare or on people's healthcare broadly within the pool. So they're pocketing 15% for administration, overhead, marketing, potentially surpluses and things like that, compensation for their executives, because Blue Cross in some states is a non-profit plan, right? In some states they're not, they're for profit. So there's a control on how much they spend, but they basically aren't required to spend as much as Medicare does on the healthcare side as a share of the premiums they're collecting. What Blue Cross is going to then do, though, is they're holding the risk for the population they're insuring, but then they're saying, like, okay, now we're going to go into contracts with hospitals, primary care physicians, specialists, etc. And all those people we're going to agree on a fee schedule with. And we're also going to agree on a process for dealing with certain benefits. So they'll say, okay, we're not going to cover a kidney transplant unless certain treatments have been delivered and a prior authorization is in place.
Mhm.
So then the physician gets into the insurance business where they have to call Blue Cross on your behalf and say, hey, I want to refer this person for a kidney transplant. And Blue Cross then says, like, okay, did you try XYZ? How long have they had the condition? Like, what are their other health factors, et cetera, and decide whether that benefit should be covered or not. So there are lots of benefits that you see as covered when you get your insurance sign up information that have to go through some level of what's called utilization management for the insurer to cover it. And that's what physicians are kind of complaining about when they talk about dealing with insurance companies, because they're doing billing, which is fairly standard. But then some of their bills are getting denied. So then they're having to call the insurance company and figure out why that bill was denied. Sometimes it's because that person's uninsured and like gave them the wrong insurance card. Sometimes it's because that's not a covered benefit. Sometimes it's because the physician put the wrong code on the form or didn't back up a certain service that they delivered. And so it gets resolved, but it's still 10 minutes on the phone. And then there's some things where it's prior authorization and like all these utilization issues they have to deal with. And one of the big frustrations, I think, for physicians is when they talk to the utilization management people, sometimes they have to escalate it to actually talk to another physician. So like at first they get customer service and they get somebody who's saying like, yep, it's denied. You didn't provide X information. And then the physician says, well, okay, I'll provide you X information over the phone. They're like, no, fill out this form and fax it back to us. And then they fill out the form and fax it back. And so it ends up being this like painstaking process. And so, I mean, from somebody navigating the system, having a physician that's like willing to advocate for you and make sure that they are doing their part to help with the insurance side of things can be really helpful. There are also companies now that are hired as navigators to sit in the middle. Sometimes they are just the help on the patient advocacy side. Sometimes they're also the person in charge of utilization management. So there's a contractor that makes it easier for patients and physicians to talk to, but because they're not part of the insurance company and they have an app and it's easier to get in touch with them, but they're still designed to like save money for the insurance company for the most part. And I think that's what a lot of physicians and people are kind of worried about when it comes to insurance companies' role in providing them with the health insurance that they're paying for.
Right, because hospitals are already kind of a fast-paced environment, depending on where you are, depending on your department, all this stuff, time of day. And I can imagine that a physician doesn't want to be spending 10 minutes on the phone talking to somebody who's being uncooperative or telling them that, oh, you're doing your job wrong, you need to provide this service, when the physician already knows they don't need that. Like, we know that he has it, or this is going to harm him. If we perform this procedure on him, it's going to kill him or something like that. I can see why those like blanket statements of you need to have this checklist. If you want a kidney transplant, you need to have this checklist down before you give it to him or we won't cover it. It's kind of a life and death thing at that point. It's really weird that it's so blanketed.
Right. I mean, I think that is a lot of frustration, and we've had kind of physician burnout issues. But I mean, going back to kind of the issue around policy decisions. So if a big reform is coming down the pike, right? Often you'll end up with the lobbying organization or trade association that represents physicians. Let's say the American Medical Association will send a survey to physicians saying like, hey, how likely are you to retire this year? How much of your time do you spend on patient care versus administration? And they'll kind of use that information to lobby government or advocate with the federal government for certain policy changes. But we are facing this time where lots of physicians are reporting burnout, partially due to COVID pandemic, but also partially just due to like how our healthcare system works. And I think it's kind of reached a boiling point. At the same time, we have fewer physicians entering certain specialties. They're coming in with lots of student loan dollars. And so it's hard to be a doctor. And so the um, I think it's a concern, right? And there are different ways to solve that problem. So in some states, it means expanding the types of providers that can deliver certain services to patients. So you see more nurse practitioners or physician assistants operating somewhat more independently to kind of replace physicians in the workforce. Um, in some places, it means physicians deciding, like, I don't want to deal with billing. I'm going to go join a centralized system. So
Mhm.
I would rather make $240,000 a year at Kaiser than make $260,000 a year at Hoag to um, do the same thing, because I know at Kaiser, like, if I follow the rules, that's it. Like, I'm going to get paid. I don't have any risk, and I'm going to be kind of a 9 to 5 shift based physician, and I'm going to get to care for my patients more often than if I'm running my own private practice and billing insurance separately, or if I'm joining a system that's not as integrated as Kaiser might be. But recent medical school graduates aren't going into like private practice like maybe their parents did. They are going to large medical groups or hospital systems or places like Kaiser Permanente because they don't want to be as engaged in the business of medicine. They want to do more medicine.
Mhm.
So like if you have there are quite a few instances where older physicians are trying to sell their practice and they can't because there's no new physician that's going to buy that practice. They don't have the capital and it doesn't seem like an appealing thing to do. I don't want to join a solo practice or become a solo practice physician that now has to deal with all these insurance companies and all the headaches that go along with it. So the places buying those practices are either big systems trying to grow their footprint or private equity. And so we're seeing like a shift into private equity in medicine that I think could be potentially dangerous, because of the fact that like the private equity firms basically come in and try to figure out how to maximize revenue. So they're like, oh, it maximizes revenue for us not to take Medicaid. It maximizes revenue for not to be in network for anybody and charge really high prices and hope for out of network clients that will pay the price and then, um, kind of change the way we deal with insurance. So, that's a risk as well. So, like, it's all a moving puzzle in a way, in that, these decisions we've made historically around medical school tuition, support for National Health Service course lots, where we put residencies around different specialties, how we deal with student loans, like that indirectly causes the move of private equity into our healthcare system because you have a bunch of new physicians saddled with student loans who have to practice in a specialty to make enough money to pay off those student loans, also don't want to work in private practice, and then private equity takes over the private practices. You end up with all these like economic issues and process issues that we probably didn't foresee 20 years ago.
So that's that's a lot. So like with these private equities, these private equity firms, are those like places where people put in their money and they say, "Here, make me more money"? Is that kind of, it's like an investment firm kind of?
Right, but it's like they aren't dealing in public stocks, so
Okay.
they're basically buying shares in entities. So if I'm part of a private equity kind of fund, then I may invest a certain amount of money, but that firm is then going and buying property or a share in a business, and so that's an investment to the business, but they require a certain return, or they'll just buy the practice overall, right? So like there have been instances where private equity firms will buy medical groups, and then that medical group will decide to do things completely differently than they've been doing and maximize revenue. So they'll become out of network when they used to be, part of the Hoag system or the Cedar Sinai system. So and then once they're out of network, they aren't under an insurance contract, and they can either decide we're going to become like a concierge type practice where we're not going to take insurance. We're just going to serve the higher income among us who are willing to pay a membership fee and pay certain amounts of money for services, or they'll become out of network in a way that enables them to bill extra to the patient that insurance won't cover. So it's a practice called balance billing, where in essence, if like you're a PPO patient, right, or a PPO enrollee in an insurance plan, a preferred provider organization, you typically have a price tag for in network and a price tag for out of network. If you're in network, you may be required to pay 20% of the cost of that service. And if you're out of network, it might be 40% of the cost. However, if you're in network, the cost is determined by a contract with the insurance company. So if I go to my doctor and they charge $200 for a visit, I'm responsible for $40 as my coinsurance, and the insurance company pays them $160. And that's part of the contract. If I go out of network, it's not that the insurance company is willing to pay whatever the physician charges. They are willing to pay $200 because that's what they would have paid if you stayed in network. So let's say you go to a physician that's now not part of any insurance company network, and they say, okay, our cost of a visit is $500. So they will bill you for whatever the insurance company didn't pay. So if you're used to paying $40 for a $200 visit, if you're going to a $500 visit, it's not that you're paying 20% of $500. You're not paying $100. You're paying probably $300 because the insurance company is only willing to pay $200 for that service, and that's it. And that's where their contract ends because they don't have a contract deal with that provider. So then you see firms being able to kind of maximize their revenue by not being in insurance networks. And the most egregious accounts of that were like surprise billing, where like it's now been limited by California state law and the federal surprise billing law, No Surprises Act. But like, let's say you went to a hospital to give birth, and the physician, the OBGYN was in network, the hospital's in network, but the anesthesiologist who came into the room was out of network. You wouldn't know they're out of network. You don't know when you're about to give birth, like to ask the anesthesiologist, you take Anthem Blue Cross.
Yeah.
So you would get a bill from the OBGYN group that would be in network, and it would be a reasonable amount of money. Then you get a bill from the hospital, and it would be like your stay in the hospital. And then you get a separate bill from the anesthesia group for $3,000 when if they had been in network, it would have cost $300. And that's considered a surprise bill. Like you walked into a hospital thinking everybody here is in network, and it turned out that one consultant on the team was out, and therefore I'm getting this bill that I didn't know was going to happen. And so now there are like rules around arbitration and things like that. But that was a major problem for a good decade or so. But now we still see that kind of balanced billing aspect, because if you willingly go to that out-of-network physician, you are accepting all the responsibility of the costs related to it.
Mm-hmm. It's no longer a surprise. Yeah.
Yeah.
I'm surprised that you were talking about before. Oh, certain physicians will be like, "I'll take 24,000 over 26 that, or 240,000 over 260,000 because I don't have to deal with all that billing stuff." So does that mean if they go to Kaiser, they're in network automatically, or can they still be out of network with the new?
So in Kaiser, everyone is in network. So the way Kaiser works, it's an HMO, it's an integrated system, and basically it's Kaiser Foundation Health Plan and hospitals have a sole source agreement with Kaiser Permanente Medical Group to staff those facilities. So there's no out of network in Kaiser. If you go out of network, you're paying the full cost on your own. Mm-hmm. There are some circumstances where Kaiser will send you out of network. So like, I think Kaiser in the Bay Area doesn't do certain transplants or burn treatments in their facilities, so they have to use Stanford for it. Like, so they're deals that Kaiser makes to make sure you have services that go out of network, but they're doing it for you. It's not like you get to choose, I'm going to go to Stanford, and then they're going to send a bill to Kaiser. So if you take Kaiser, you are accepting the closed network HMO. If you sign up for Anthem Blue Cross PPO, you have an in-network option and you have an out-of-network option. So then you're kind of trying to find in-network physicians. But if you go to an out-of-network physician, you get some partial reimbursement. It's just often not the partial reimbursement that you would expect, because people don't realize that it's the price that the physician wants that is governing the bill versus this contracted rate that you're used to seeing from in-network providers.
Right. So like with something like Hoag, for example, could there be like a mix of in and out because they're not like I'm not sure what the correct term is, but they're not the same organization as Kaiser, for example?
There could be some risk of that, where especially when it comes to maybe things like anesthesia or emergency room, because you don't really know how physician staffing arrangements are made in a hospital setting. So some practices are aligned with Hoag. Like there's kind of a Hoag family practice group. And then there are some practices that might be located right outside of the hospital setting that just happen to locate their medical group in that area. And they are all they all have privileges at Hoag and are able to admit, and they end up being part of the care team. And then there might be others who are under contract to deliver certain services. And so you'll see that a lot in emergency medicine and anesthesia, where it's a separate private practice, usually a medical group. And they may not be in every insurance company that Hoag is in network with. So Hoag may have contracts with 6 different insurers, but the contractor they use may only have 2 of those 6 contracts. So for every patient who walks through the door and needs anesthesia, 4 of them might be outside of network. So with like things like elective surgeries, you kind of need to make sure that your care team will all be in network. It's not, because of this No Surprises Act and the California limitations on surprise billing, it's not as bad as it used to be, but the price can still be a little bit higher than you would expect, because instead of now being able to charge you whatever they want and balance bill you for the difference, now they have to go through an arbitration process. And so there's basically a committee that will decide, based on existing rates and like existing contracts, what is a fair price. So you'll probably end up still paying more, but it won't be as much as would have happened 5 years ago before all these laws went into effect.
Okay. So you can still be outpatient, or you can still be out of I guess out of that partnership.
Mhm.
But you can still exist in that hospital is what I'm trying to say. Like,
Yes.
okay.
Yes. It gets into all other things about what counts toward your deductible and what counts for your out-of-pocket maximum. So
Okay.
all related to the complexity of our system. But yes, I mean, they're not going to turn you away. And if you're in an emergency situation, that is like covered by court cases and other law, where you're basically protected from out-of-network billing in an emergency situation. So if you ever get an out-of-network bill for an ER visit, you should actually fight it, because HMOs and PPOs, every insurance company is required to cover emergency room at in-network rates. But everything else, like if you're getting, I don't know, a hip replacement and the anesthesiologist is out of network for that hip replacement and you didn't know, that's considered a surprise. You can send that bill to this arbitration process, and then it'll get negotiated down to a more reasonable rate, even though it would probably still be at a higher rate than what you would have paid if you had insisted on an in-network anesthesiologist been sitting in the room. That being said, whenever you call an insurance company, it can be difficult or an insurance company or a provider, it can be very difficult for them to actually tell you who's in network and out of network.
Mhm.
If you look at the website or an insurance book or, network book, some of that information is out of date. And the names for plans are all different. So like if I call a provider today, and they might say, okay, what insurance do you have? And you're like, all right, I have, the Anthem PPO. They're like, which one? Is it the one offered by the UC system? Is it the one offered by a different employer? What's the name of it? Is it the Prudent Buyer PPO, or is it the, Covered California PPO? And the networks are all different. So even providers don't necessarily know when somebody's calling them who they accept. And then the insurance companies, often because of differences in medical record, or physician IDs and business licenses, won't necessarily know who's in their network. So if you call somebody and say, if you call Anthem today or another insurance company today and ask them, is ABC Medical Group in my network? They might say, we don't see ABC Medical Group in your network. But if you tell them individual names of physicians that work at ABC Medical Group, then they can find them, because they have them listed under their physician name, not under their practice. So you have to do a lot of work to kind of navigate on your own to figure out, who to make your care team and if they're actually in network or out. And a lot of times you'll call them like, oh, we no longer take that insurance. So then something changes overnight where you're kind of caught off guard. So if you're receiving care from that physician already and they say, hey, our contract with X insurance company is going to be canceled tomorrow. There are state laws that protect you for receiving continuing care. They can be, the review process um, can be kind of challenging. So you basically have, like, the physician and you have to document what treatment you were on, and kind of show why discontinuing that treatment and having to find another provider would be troublesome. So if I have a cancer diagnosis and I'm going through like a very specific chemotherapy and radiation protocol, the insurance company will probably approve it. They'll be like, okay, you have a year to like finish up that treatment protocol before you find a new physician. So we're now going to enter into like a one-off contract with that physician to pay them X amount of money per service, but we're not entering into a contract with their entire group. We're just entering into a contract for this circumstance with them. If I'm a brand new patient and I'm hunting for a provider to go to and they say, sorry, your insurance isn't accepted here, there's really nothing I can do except if everyone I call says that. I don't take your insurance. I don't take your insurance. So you have nobody to go to in your entire area. You can complain to the insurance company and say, you don't have an adequate network in my area. I can't find a neurologist within 50 miles. So find a neurologist for me. They kind of have to do that. If they don't do it, you go to the Department of Managed Healthcare in the state of California or the California Department of Insurance. If you're outside of California, you go to your insurance commissioner and you make a complaint, and then they will follow up with the insurer and like make sure that they have an adequate network. Because part of being licensed to sell insurance in the state is having an adequate network to deliver the benefit you're being paid to deliver. So if you end up running into a situation where you actually can't find services because your insurance doesn't have those folks in network, as long as you kind of make a best effort to find somebody and you're turned down at every turn, and then you call your insurance company and they can't find anyone, they basically have to find someone for you who may not be in network. So I wouldn't just accept the out of network. Like, I would try really hard to find an in-network provider, but if you can't, there is some recourse where the insurance company and the state can be aware of it so that people are working to find you somebody and they will protect you in the kind of billing scheme. And usually they have these kind of one-off agreements. Sometimes if you see an out-of-network provider and you're able to demonstrate that there was not an adequate network beforehand, they call them repricing agreements, because you'll get this giant bill, then you'll go to your insurance company and you'll say, you better pay part of this bill because I couldn't find any other doctor that would see me. Then the insurance company will say, fine, we're going to go negotiate with the provider, and they'll create a repricing agreement for your circumstance only. And they'll say, like, we're going to pay you 70% of what you charged. Versus if you do it up front proactively, you end up using kind of like a one-off contract that just governs your care.
Okay, so you can still take advantage of your in-network stuff if there is no in-network
they will
physicians.
treat them as in-network. From your perspective, you may not care as much about the pricing. Like if you're in an HMO and you're going to pay a $20 copay for your office visit anyway, regardless of where you go in network, if you can't find someone in network and the insurance company finds somebody out of network for you, you should still be guaranteed to pay that $20 copay, regardless of what the person they found charges them. So like they could be twice as expensive, but you're still supposed to be governed by that $20 on your insurance contract. If you're in a PPO and they find somebody, you are the price you pay is dictated by what price they agreed upon with the insurance company. So if the insurance company agreed to pay them $300 for the visit and your co-insurance is 20%, you should be paying $60 out of pocket. And that might be more than you would have paid if you were able to find an in-network provider who are typically taking $250 a visit.
Okay. So if I'm in Kaiser SoCal, for example, and I travel out, I'm in Minnesota or something, and I have an accident while I'm hiking or something, and I get helicopter rescued. It's like a huge bill. I get flown to the nearest hospital because I'm dying. Like, is there any recourse for me then? Because I can't like select which hospital I want to go to.
That will be covered as an emergency room visit. So it will be paid at in-network prices because it is an emergency. So in an emergent situation, you shouldn't worry about it. almost identical situation, except I didn't have to be helicoptered out. But when I was a grad student in DC, I was covered by like the GW, George Washington University Health Plan. And I was skiing in Tahoe and hurt my neck skiing.
Hmm.
And so I went to like Tahoe Regional Hospital. They took care of me, and they bill George Washington University Hospital because they have my insurance information. And GW Hospital's like, here's your bill for, you have to pay $100 of it. And then they cover the rest because in an emergency situation, they deal with it. But if you were to fly to Minnesota to go to the Mayo Clinic and they are not in network and you are doing it on purpose to get cutting edge care from the Mayo Clinic, then you face these like surprise billing and balance billing issues.
Okay. So what, I guess, qualifies as an emergency, right?
Mhm.
If I'm having like severe stomach pain, for example, like it could be appendix related,
Right.
like.
So it's supposed to be something that a typical person would think is an emergency.
Okay.
So you're pretty protected there. Like if your symptoms are severe, you can't walk, you're vomiting a lot, like all that stuff. They don't expect you to be able to determine what's emergency or what's not.
Right.
If you're a Kaiser patient, though, they have a nurse triage line that you're supposed to call. So it's always a good idea to turn over your insurance card, call the line. If you're brought in by ambulance, usually they're like, yep, emergency. But if you're kind of able to ambulate and or get dropped off or something like that, and your condition could be, something like flu and dehydration, calling the nurse triage line is helpful because they will direct you. And if they say go to the ER, then you for sure that they're going to determine that's an ER visit. But if they tell you, oh, go to urgent care, then you have a signal that you should go to urgent care, because if you go to the ER, they might say, we direct you to go to the urgent care. You didn't. You came to the ER, and it turned out not to be a problem. The convenient news is, a lot of Kaiser urgent cares are like right next to their ER on their hospital campuses. So it's not super dangerous to, be a 5-minute gurney ride away from the ER. But sometimes people go to urgent cares and they're given, incorrect diagnoses or bad advice, and then something worse starts happening and they end up going to the ER. But urgent cares know about that in terms of liability. So if you're reporting certain, urgent cares will turn you away. So I think calling ahead is a good idea. If you're unconscious and, things are really serious and you're taken by ambulance, that will be determined to be an emergency room visit. But the line is pretty forgiving for the consumer in that we aren't supposed to know what is emergent. So if a typical person would judge it to be emergent because like you're in such pain or uncontrollable situation that you must end up in the ER, then they'll cover it as an emergency room visit.
Okay. So this insurance is very important in terms of like, if you don't have insurance and I'm rushed to the ER, I don't have any in-network privileges.
Mhm.
I'm just going to get slapped with a bill after whatever neck injury, right?
Right.
So I noticed with the ACA when I was reading up on it, there was this gap where a lot of undocumented people, undocumented immigrants coming in, they make a little bit too much to be covered by Medi-Cal, I think it is. So and they don't make enough to get private insurance. Are there any efforts right now, if you're in that gap, to get you insurance?
Right. Well, so first I should clarify. So California is a unique situation in that we recently expanded Medi-Cal, which is our Medicaid program, to include undocumented immigrants. Before they weren't allowed in. So when the ACA was written in 2009, 10, and passed, and then implemented in 2014, undocumented immigrants were excluded from the Medicaid expansion, as are legal permanent residents who have lived in the U.S. for less than 5 years. So if you haven't had a green card for at least 5 years, you can't get into Medicaid according to federal law. You can get into the insurance exchanges and buy coverage with your own money as well as some federal money if you're a lawful permanent resident with a green card. Undocumented immigrants aren't allowed into the exchanges. So you end up with kind of two groups. So people who are undocumented immigrants from 0 to 138% of the federal poverty level, which is like $14,000 a year, And then anyone from about 14,000 all the way up to around $50,000 a year, they are, if they were citizens or legal permanent residents, would qualify for tax credits. But because they're undocumented, they don't qualify for tax credits to buy insurance, and they're not even allowed to sign up insurance through the exchanges with their own money. So I think in California that might be like 1.2 million people or something like that. State, nationwide, it's probably 3 million people, a little bit more. So California decided back in 2014, first, we're going to allow lawful permanent residents who haven't met the green card, the eligibility bar for 5 years, into Medicaid with state dollars. Then in 2024, we finally expanded Medicaid. So any undocumented immigrant earning up to 138% of poverty level would be allowed into Medicaid with state dollars. So that's an expansion that happened very recently. But there's still about 500,000 people that make between 138% of poverty level and up who are undocumented, who don't have access to any other source of coverage unless their employer offers them coverage, or they make less money and end up in Medicaid, or if they get like pregnant, then they end up in Medicaid because the pregnant women eligibility over for Medicaid goes up to about 350% of poverty just for that year. So it's a patchwork to navigate, but so you still end up with kind of a middle income group or low to middle income group of undocumented immigrants that don't have access to any affordable source of insurance. So there are a couple ways that California deals with that and other states as well. So the first is California has this law, Welfare and Institutions Code, and one section 17,000, says the county is the provider of last resort for residents of the county. Different counties, depending on their politics, decide who qualifies as a resident. So if I'm in Orange County, we don't count undocumented immigrants, even if they can prove they live here, as a resident for the purposes of that program. If I'm in LA County, they say anybody who has an address in LA County is a resident. So if I'm in LA County and I'm undocumented and I'm above the Medicaid eligibility level but can't afford insurance, I can go to the My Health LA program and get assigned to a primary care doctor who's in a federally qualified health center or a other county clinic. And then I have access through to hospitals through what's called the Ability to Pay program, which is kind of like a sliding scale subsidy program. So I still have access to healthcare. And if I show up at an ER, any ER, they have to stabilize me before transferring me due to federal law, EMTALA, the Emergency Medical Treatment and Active Labor Act. So there's some access, but no insurance coverage. And if I don't go to the county and I do end up in an emergency room, even though they have to stabilize me, they can still bill me. So, and they can bill me whatever price they want up to the highest charge they might charge another client. And there's some protections due to like a Hospital Affordability Act that passed several years ago for people earning up to 3 times poverty. But if I'm a undocumented immigrant, uninsured, who goes to Cedar Sinai for an ER visit because I, got hit by a car crossing the street, it's very likely I'll be charged like $12,000 for that visit, even though an insured person would be charged $1,200 for that visit. So then it's up to me to say like, oh, I don't have the money to pay for this. Let's negotiate the price down or not pay it at all and get sent to collections, have my credit ruined, all these things. And on the medical debt side, there's a lot of federal effort and state effort around, not reporting medical debt to consumer credit reports and potentially forgiving some medical debt. But that's just another kind of Band-Aid on a problem that could be solved by having more comprehensive insurance coverage. If I want to buy insurance and I'm undocumented and ineligible for Medicaid or Covered California or another health insurance exchange, I can buy it on the open market. And I benefit from the Affordable Care Act in that the benefits required in the individual insurance market are the same, whether you buy coverage inside or outside of a health insurance exchange. So I can still get the same plan that's like offered by Covered California outside of Covered California. The problem is I have to pay the full price of the premium. So I get offered coverage, but it may not be affordable for me. I believe some insurance exchanges and possibly Covered California are going to try to push for state subsidies that would be available for undocumented immigrants or anyone who doesn't qualify for the federal subsidies to participate, but they would need to sign up that person in a separate category, like because there's federal law saying undocumented immigrants aren't allowed in the state health insurance exchange officially. So, you could have policy options could be giving people a tax credit. So if they, that's funded by the state, not federal dollars. So if they go sign up through an insurance broker, prove their income is a certain level, they would use their state tax return to get reimbursed for some of that premium. So there are some kind of policy choices out there, but they are probably fairly onerous and they're not seamless, right? You end up with people thinking like, oh, I heard Medi-Cal now covers people regardless of citizenship status. I'm going to go try to apply. You go try to apply and they say, sorry, you make $100 too much.
Mhm.
Okay, what are my options now? Like, I'm not directed to Covered California anymore. I don't get directed to an insurance broker to then navigate and get that tax credit. So like, I think, there's an ability in the ACA. There was a provision around having a no wrong door approach to insurance sign up and eligibility, where wherever you started, you could make it to the finish line. But that's not true for undocumented immigrants because they hit these roadblocks that are impassable, right? So they're often reliant on kind of county and state subsidy programs or safety net programs. So it's not to say they don't have access, but they don't have great access, especially if they have a chronic condition or like a cancer diagnosis. They can kind of access primary care. They can access emergency care. They might have a county hospital in their area that provides some support, but they don't have the same generosity of benefits that, a typical insured person does.
Right. Like, especially, well, I don't know about, well, I guess I'll ask this. Do other states also have, or what other states also have this provision for undocumented immigrants?
I think there might only be two. I think New York has some semblance of it. And then I know Maryland is pushing toward doing something, or some advocates in Maryland are pushing towards something. So no other state is as generous, I would say, with full Medicaid benefits paid by the state for undocumented immigrants.
Okay. And I guess that's why in the studies I've seen, that's why you see a lot of people, undocumented people, especially using the ER a lot more. It seems like it's a lot more straightforward. Like you're pretty much guaranteed to be in, I guess it'd be in network, you'd be covered. Whereas with primary care, it seems like it's a real like gamble. Like you're calling and calling and calling and nobody's picking up. Kind of just figure, well, nobody takes it. I'll just go to the ER because I need to get this done.
Mm-hmm. Well, there's some evidence from a few years ago from Alex Ortega, who's now the dean at University of Hawaii. And he found that uninsured people were least likely to use the ER because of the cost implications. So it's not like uninsured people necessarily know I can get this bill forgiven or subsidized or somehow get out of paying it. They actually are confronted with this like potential for a very high cost ER visit. So the barrier to entry for an ER visit is much higher for somebody who's uninsured. So like lower income and undocumented uninsured people are probably less likely to use the ER than people who have Medicaid coverage. So once I'm in Medicaid though, then I have financial protection. And actually, because of the way Medicaid is structured, there aren't coinsurance and copays or premiums for the most part. So I actually have more financial protection if I'm in Medicaid. So if I can't find access to a network provider in my area, at least I have the stopgap of going to an ER. It'll be covered and it won't be any cost to me. So I think the evidence does point to like Medicaid and private insurance patients using the ER more than their undocumented or uninsured counterparts. And I think that's a kind of normal thing to expect. Like if you get insurance coverage, you are more likely to use health insurance. And like, you're probably 30% more likely to use health insurance than, or use healthcare services than somebody who's uninsured. So there was a concern when the ACA first passed, like you have all these uninsured people who are now going to move into coverage. They should have pent up demand where their, utilization increases and then they hit some normal where like they're getting maintenance care. So they priced premiums in Medicaid very high originally, at least here in California, to kind of absorb it. And it turned out that the estimates were kind of off. So they actually used fewer services than expected, but more than they used to when they were uninsured. So I think that's encouraging, where a lot of the groups we're expanding coverage to are actually fairly healthy. Because if you think about Medicaid, like you could already get into Medicaid with a disability if you're over 65, if you're low income and pregnant, if you're low income and had a medical need. So the people we're bringing in through the Affordable Care Act's Medicaid expansion and now the undocumented expansion in California tend to be a little bit younger and healthier. So they're not actually costing that much money. So then the hope would be, if they're getting preventive services, if they're getting primary care, they avoid future chronic illnesses, they avoid future high cost cancers, and hopefully there'll be maybe not a savings, but at least a stability in healthcare spending now that we're at this new level where you almost have universal coverage, that everybody should have kind of a equitable way to get care.
Yeah, and even with that knock-on effect that you see in the economy, if you prevent this chronic illness by catching it early, something like cancer, or if you allow these treatments to occur pretty early on, it's nice because these people aren't going to be kicked out of work, right? If you have if your lung cancer progresses across the years and then all of a sudden it's so bad that you're stuck to a bed, you can't work anymore. But if you catch it early on, you can work for the rest of your life, hopefully, retire. So it seems to have, at least in my thinking, it has a knock-on effect on the economy, increasing the taxes, increasing the available budget, I guess.
Right. Yeah. So there's certainly, well, one thing is, so when we look at the federal budget, so the Congressional Budget Office is required to analyze bills that would add to the deficit over typically a 10-year window. Sometimes there'll be a special bill where they'll analyze it over a 20-year window. A lot of the savings and benefits of new social programs and new health programs aren't actually realized within 20 years. So sure, yeah, people will probably have longer life expectancy. They'll have a longer work life expectancy. They'll end up in aggregate generating more income and therefore more federal tax dollars. But maybe that won't happen in the first 10 years. So from a federal perspective, it's hidden to the legislator making the decision.
Mm-hmm.
From a health insurance perspective, for the most part, we are considered a risk for a year at a time. Our premiums change each year based on the underlying risk of the entire pool. But a health insurance company doesn't know if they should invest in our health now, and then they're going to lose us next year to Kaiser. So they kind of make these decisions based on current time point. And so generally the hope is for them to kind of avoid spending lots of money on things that they view as unnecessary or not medically necessary. Because it is better financially to kind of kick the can down the road or say oh, we don't actually think this will have a financial benefit. Now, there are, of course, countries that use evidence to determine how to deliver healthcare, right? So if I'm 80, should I get a hip replacement? Perhaps all that spending on a hip replacement when I'm 80, if my life expectancy is 82, isn't all that effective. And so you have more centrally controlled clinical decision making that's occurring based on thresholds around the increase in life expectancy, quality adjusted life years, or kind of the ROI of that specific procedure. So I think if we move to a more equitable model, you'd still have to face those trade-offs where we'd have to determine societally, probably through a set of commissions and lots of physician groups that would make determinations, where does the responsibility stop? If there's a marginally beneficial service that you could get that costs lots and lots of money, if we're in a more tightly controlled system, you probably don't get that service. In our current system, as long as there's a physician willing to give it to you and your insurance company is willing to cover it, it'll happen. And a lot of in Medicare, as long as it's in the benefit package, you can get it. So you could have somebody get a hip transplant at age 83 and they could die a year later, there's not going to be any controversy about giving that hip replacement to that patient at 82 in Medicare because of how they process claims. Like there's no prior authorization requirement. There's nothing that would get in the way of a physician delivering that service. And you see that now with like lots of seniors getting cataract surgery where like they probably have a cataract that's marginally effective, or that where surgery would marginally effective and it may not last a long time, but there are physicians out there, generating business through delivering lots of procedures that they can do in a health insurance environment that's less restrictive of their reimbursement. So they're not doing lots of cataract surgeries for, people who are 64 in private insurance because the insurance will say no. But if you're in Medicare, you can deliver lots of services kind of under the radar. And it may not even be considered kind of fraud or abuse when you're doing that.
So is there a certain breaking point where, like you said before, that a lot of physicians don't take Medicare because of all the
Medicaid.
nonsense, or Medicaid? Yeah.
So lots of physicians take Medicare. Medicare is basically priced in a way where the government controls the fee schedule, and they set it each year based on kind of the value of the things you are delivering. And they multiply that value by this dollar amount. So each year it's updated, and it's still low, but it's basically enough to cover costs. The insurance that lots of providers don't take is Medicaid, or Medi-Cal here in California, because it pays much lower. So like historically, I think California has been like 48th out of 50 states in terms of Medicaid generosity on price. And so you would have a Medicare service that's paying $80 a visit, and the Medicaid version of that would get $22. And so physicians would say, like, I'm not taking Medicaid because I just lose money on every patient, unless they're just trying to generate revenue, or they like have open slots, right? So if I'm a new physician that has 40% of my visits are open in a given day, I might as well fill with somebody who's generating $22 a visit. At least it's not zero. But if I have a busy practice and I'm having to turn people down and have long appointment wait times, and I can generate all of my income through Medicare and private insurance, then maybe I don't take the marginal Medicaid patient because the reimbursement is low. There was a law that was passed a couple years ago that updates the Medicaid fee schedule. So certain services like primary care, and some outpatient specialty services, the reimbursement rate is going up to 87.5% of Medicare. So it'll get closer to Medicare. So the hope is that more physicians will start taking Medicaid in California. Of course, that's because our Medicaid program is mostly managed care driven, operated by private health plans. The private health plans are being told you must pay X amount of money to your primary care network, so they are correctly paid, and then we'll just give you more money in the premiums we're handing down from the state to cover the difference. So there's money in California being devoted to that, and some states have been very good about that over the years. Like Texas actually does a decent job of paying physicians and hospitals, but they do a poor job of allowing people into Medicaid. So like they have very low eligibility levels, and they didn't do the ACA expansion. But once you get into Medicaid, the physicians are fairly compensated, so it's not that hard to get a provider.
So that's interesting. So like, what seems like you want to be on, like, at least in California currently, we want to be on Medicare because more doctors take it. What are the qualification differences between Medicare and Medicaid?
So Medicaid is for low income under 138% of federal poverty level, so around $14,000 a year. You have to be, now at this point, you could be a citizen, green card holder, or undocumented. If you are over 65 and you're low income, you could want to be on Medicaid for at least part of your services because they're the one payer in town that does custodial long-term care. Medicare covers rehabilitative long-term care. So if you come out of a hospital and you have 100 days of skilled nursing needed to rehabilitate from that hospital stay, then it's covered by Medicare. And they're paying like $400 a day or more for that rehab bed. If you don't come out of the hospital and you're over 65, even if you have Medicare, Medicare doesn't cover custodial stays, meaning like you're not going to improve.
Mhm.
Like, so let's say you have, dementia or whatever, and you need to be in a skilled nursing facility. Um, Medicaid would be the only place that would cover it, but they would only cover it if you're low income. So you do have seniors spending down onto Medicaid, meaning like they have to exhaust all their resources and become low income. Then they get on Medicaid because that's the only place that will pay for their custodial needs, because they're going to be in a skilled nursing bed or home health for the rest of their lives versus rehab, where once you improve, you leave, right? So Medicaid does end up being important for disabled, over 65, and then low income. It's really important for kids. Medicaid covers up to 267% of poverty for kids. So you do end up with parents where like the child is in Medicaid and the parent is in a covered California plan or their employer plan. And kids, like there's a lot of evidence showing that if you have Medicaid early in life, you have better job prospects, better income, more likely to complete your education. There are all these like developmental advantages of having insurance coverage early in life. So Medicaid ends up being like a safety net program for kids up to 267% of poverty, adults up to 138% of poverty, women who are pregnant up to about 350% of poverty, and then older people who have custodial skilled nursing needs who are under 130% of poverty or so. Then Medicare. And so, like, if you are in one of those programs as a child or parent or elderly person, Medicaid is probably going to provide the best benefit coverage, but reimbursement is lower. So it can be harder to navigate. Like it's harder to find that custodial skilled nursing bed where they're only paying $100 a month or a day for. Once you move to private insurance, you give up some in terms of benefits. You end up having to pay premiums in the individual market with Covered California and health insurance and healthcare.gov. Your premium is linked to your income. So the federal government kicks in a tax credit to make sure you're not spending more than about 10% of your income on premiums. If you're in the employer market, it's driven by how much your employer wants to subsidize you. So it is better to be in a larger firm from a health insurance standpoint, because firms with more than 500 people almost always provide health insurance to their employees working more than 20 hours a week. And it's a pretty robust benefit. And you probably have lots of choices to choose from in terms of which plan to sign up for. If you're in a firm with 20 people in it, you may have one option if they offer health insurance at all, because they're smaller and not able to afford it. And then you have, so that's one part of the private insurance market, which is very employer driven. Insurance's benefits are broad. Reimbursement is much better in that market for the physicians. So physicians are more likely to accept your insurance if you're in an employer plan. And you probably have more choices. And in a given year, you could probably switch at open enrollment to a new plan that better meets your needs. So you're not like worried about canceling one plan and being rejected from another. You're able to move kind of seamlessly every year to a plan that meets your needs, depending on the situation. Now, if you're in private insurance, but on the individual market, where you're buying through a broker or through healthcare.gov or Covered California, you benefit from federal help if you earn a certain amount of money. And the federal help gets better as you go down the income scale. So if I'm earning 149% of the poverty level, probably like $18,000 a year, I get substantial tax credits and discounts on my deductibles and copayments by signing up through a health insurance exchange. Whereas if I'm earning 6 times the poverty level and signing up in private insurance individually, I don't get much of that help at all. So the private market, you risk paying a higher premium, but if you're low income, you get lots of help. The networks are more narrow, because to make the insurance products more affordable, the networks are different than the private employer market. So if I sign up for an Anthem PPO through Covered California, the network is going to be different than the Anthem PPO I sign up for through my employer. And so that can be a sticking point and a confusing point as well, because you have to be really exact about like the name of your insurance product that you're signing up for to understand who's actually in your network and where you can go. And then in the private market, on the individual side, you see a lot more deductibles and a higher level of cost sharing than you do in the employer market. So you're more likely to see, $2,000+ deductibles, $50+ co-payments. Whereas if you're in the employer market, they try to keep those a little bit lower, but your employer is subsidizing it. So it's not like it's not costing you money. Basically, the employer is deciding, in order to provide you with a generous benefit package, we're going to spend all this money, but that may be why your wages go up at a slower rate or don't go up at all in a given year, because health insurance costs may crowd out the amount they had for giving everybody a raise or bonus.
Okay. The that one statistic you said earlier, I think it was about undocumented, or no, it was about, what was it? Children that were on Medicaid, I believe, had better outcomes. Was that before, like, is this in California? Was that before the undocumented immigrants were able to get it?
Yeah, this is historically, like, going back to, so there's a couple papers, one by Andrew Goodman Bacon, I think Laura Wary from NYU has one, and then Michael Boudreau at the University of Maryland have all separately found like these developmental advantages and increased, less likely to being unemployed, higher incomes, higher education completion among Medicaid recipients. So they've looked at data, I believe, from the census, where they're able to track people over time. And so they had to go back, a good 30 years to find people who were old enough now and had been on Medicaid. So this is pre undocumented expansion and pre ACA pretty much. But you could expect similar outcomes, right? So if you have undocumented kids currently getting into Medicaid now for the first time and getting insurance coverage, their outcomes are likely to be better in California than they would have been if they were in Texas, where they're locked out of health insurance coverage. It's like they're actually able to get, dental visits that deal with their cavities beforehand through their Medicaid benefit, whereas a kid in Texas might be dealing with a toothache and dealing with extractions and missing school and not being able to concentrate. And there's this kind of domino effect when you have health issues as a child, where you're missing school, not able to concentrate, and then you probably end up with poorer outcomes compared to other people who are.
Yeah. So with that, actually, that leads into one of my bigger questions about preventative care, because you're talking about how, like, even something like you think of as now as like a toothache, it's annoying, but it can cause a lot of knock-on effects. Like, if you're a child, especially if you're not gonna be able to concentrate at school. Maybe you need to have multiple dentist visits in order to, like, oh, here's the analysis of it. Here we're going to do the extraction. Here we're going to do a checkup. You have to skip school multiple times. Impacts your future performance. What can we do to better our preventative care side of it? What can we do to make sure that that it doesn't become a root canal, for example?
Well, so I think, having the benefit is one part of the pie. So, the fact that Medicaid includes dental benefits is important. In the Affordable Care Act, it includes a provision that says pediatric dental must be included in individual market benefits that people purchase. There's no requirement in the employer market that firms offer dental benefits. So dental insurance rates are lower than health insurance rates. That being said, some people who are offered dental benefits turn it down because, like, the cost of getting a cleaning once a year or twice a year is probably cheaper than signing up for health insurance. But I do think, if there are crises, there's a lot more evidence that dental services are delayed due to cost than medical services. And I think there's, like, a difference in perception around them, but also the coverage issue. But that's one example of prevention, right? So, but there are lots of preventive services that are included in Medicaid, in Medicare, in the Affordable Care Act preventive services mandate with no cost. Some are things like for older adults, like cancer screenings at a younger age, et cetera. And they have to be on the U.S. Preventive Services A or B task force list. So they have to have a grade of A or B in terms of the effectiveness of the screening or treatment. And then there's some women's health things from the Health Resources and Services Administration that must be covered at no cost, like birth control pills, for example. But those preventive services often don't pay off very quickly. And if more people are accessing them at a younger age through their health insurance benefit, there are still some negative effects of, like, radiation exposure, false positives that result in stress, follow-up diagnostics, all those sorts of things. One of the weak points of the preventive services mandate is once they have a finding, things switch into diagnostic mode, and then it's not free anymore. So like if you're getting a colorectal cancer screening at age 45, which is advised now, if there's actually a finding, the screening is free, but all the subsequent like coming back in for another screening and biopsy and all those things end up costing money. So there could be some unforeseen consequences of like once the case turns from preventive to diagnostic. But generally, preventive services are viewed as a way to save money long term at an individual level. You're like, oh, I'm going to keep this person from having a stage 4 cancer case. Instead, that's going to be diagnosed at stage 2. I'm going to save their life. They will live longer. But the treatments they may need, the follow-up services they may need long term might cost more money than if they had just gone without, right? So there's kind of this trade-off between cost savings and cost benefit analysis. So if you're to do a cost benefit analysis, you're looking at like, okay, what would their foregone benefit to society have been if they died early of cancer? Then the calculation can get positive, right? Where, they're generating more income over 20 more years of life, and their children are able to have a better outcome because they had a second parent in the house or whatever. That isn't seen when we're just doing this very like clinical cost allocation. And it's difficult for us to calculate what a life is worth or what like saved life years are worth. But people try to do it, right? But we may end up in a world where that's a very common occurrence if we use more evidence-based decision making in terms of the benefits we want to provide people and cover. So I'd say generally the guidance has been over the years, we like to talk about prevention saving money, but it actually doesn't save money to the healthcare system necessarily. It saves money probably more broadly over many years. So it may save money. There may be an ROI over 50 years if you try to catalog everything, like the social benefits, the family benefits, the child development benefits, the tax dollars you would have gotten from that person living an extra 10 to 20 years. But when we just look at like, oh, if we put this person on a screening path where they're getting diagnostic services and then we find something and they end up on chemo and that's expensive and then they end up with all these surgeries, versus somebody not being screened and dying early, like not being screened and dying early is much cheaper than getting lots of care and having their life extended, because that person individually is going to live a lot longer and generate more healthcare costs. But that has to be part of our like value system, right? I think that is in our overall value system as a country and as society. But from an insurance company's perspective, like if I'm looking at people in a 1-year window, giving them extra screening and all these services now cost me money now, and I have no guarantee that I'm going to benefit from the gains later. So I might be saying, well, if I treat them now, they're going to be healthy for the next 20 years. Great. But are they going to be my customer 20 years from now? Probably not. Maybe they'll move. Maybe they'll choose a different job. Maybe because they got all these services from me now, they will leave to join a lower cost health insurance plan later. And so I'm not as an insurance company going to benefit from this investment. And so that's where I think there's this disconnect where everybody says, well, oh, insurance companies should be like very willing to do preventive services and very willing to spend to like make people healthy, but their perception is kind of on a yearly basis because they don't have any idea of if those customers are going to stay with them, and they're making like decisions about their bottom line in a very short window.
Yeah, and I never thought about it that way before. Of like, well, homeless people, for example, they still require care. The amount that they're putting into the system compared to the amount that they're taking out is not a lot. And so if you do a pure cost benefit analysis and you're like, well, if they die, it's free. It's like, ooh, that's obviously not a favorable outcome.
Right.
But I can see where that cost benefit, just like analyzing it purely, not caring about human life, just analyzing purely on money can definitely discriminate against some people. Right. There's also what was the other thing? I don't know. I think I just mainly wanted to focus on that. I guess it gets into your health equity thing that you were talking about before, where some people are less likely to contribute to the economy, and so it's harder to make a push to politicians being like, look, this will benefit you later, not only because it's 50 years from now, but also because they could be not even eligible to vote, or they're not providing much of a tax basis. So,
Right. Yeah, I mean, if you think about the way our political system works, voters are valued and local businesses and other constituencies are valued by elected officials. And so the people with the least amount of voice are kids, undocumented immigrants, legal permanent residents, all who are contributing to the economy in some way, and to society, but their views are often kind of ignored by people in power because they don't have a direct ability to elect or advocate for themselves in the same way that institutions do, like a hospital or health insurance company located in the state, or constituents that will vote, in the next election.
okay. So I guess as like a quick closing thing, what is your biggest piece of advice for navigating this health insurance market? And that's a really broad question, but like, I guess what would be the best one for like, if you're on Medicare, Medicaid?
Oh, let's see. Well, I mean, I think broadly, it's important to know how insurance works. So learning what a deductible is, learning what a copayment is, learning what coinsurance is, learning what a premium is, knowing what's in network and out of network, and knowing kind of how to pick a plan. So one of the projects I often have students in my undergraduate class do is like shop for a plan in different scenarios, and like first day on the job, when you first get your first career position with benefits, how do I pick my health insurance plan? And you'd be shocked how many people like feel completely lost in that example. But a lot of the students come back years later and they're like, oh, that was like the most helpful thing I learned in your class, because when I got my job, I didn't know what to do. And then I was like, oh yeah, I remembered I need to pick the plan that has a somewhat low premium, but has a pretty broad network and has deductibles I can afford. And I need to kind of do a calculation in my head about what my healthcare costs will be in a given year and what's unpredictable and what's not. So I think doing that on a yearly basis, just thinking about like, okay, what do I need to do this year? What am I worried about? Am I actually a risky person from a health insurance standpoint? Might guide plan decisions. When it comes to Medicaid and Medicare, I think with Medicare, people have to do the same thing, because you do have to decide if you want to purchase like a Medicare supplement plan, if you want to sign up in a private Medicare Advantage plan, which have been under fire recently around pricing and the benefits they provide. With Medicaid, I think it's really important to understand what plan you're getting assigned to, and if they have the providers in network that meet your needs, because it's somewhat arbitrary. And so you can be assigned to a health plan that may not have your provider in the network because you're being assigned by the county. But you do have recourse. Like you can change a plan every month if you wanted to switch to the provider you wanted. So there's knowing your rights within the system, knowing who to go to when it comes to questions. It's important for people to know when they're in private insurance, if they're in a state regulated product, which means like I'm buying it through healthcare.gov, I'm buying it through Covered California, and it's considered a standalone like health plan offering, then you're protected by your state insurance commissioner, or in the state of California, the Department of Managed Healthcare. If you're in an employer plan, you may be in what's called a self-insured plan, meaning your employer hired a third-party administrator, an insurance company, to deliver the billing information and pay all the claims, but the employer is actually the bank. So you're not actually in an insurance plan at that point. You're in like a employer-funded benefit, which is not covered by state law. It's only covered by federal labor law, and it's less protective than state law. And so some people are like, well, I'm supposed to get this screening, I'm going to complain to the Department of Managed Healthcare. But if they're in a self-funded plan, they have nobody to complain to. They're like, oh, you're out of our jurisdiction, you have to go complain to the Department of Labor. And that's not a pleasant situation to be in. So knowing who to go to and how to like alleviate these kind of disputes, a lot of it will come down to your provider network as well. So knowing how they are paid, what they should be paid, paying attention to your explanation of benefits and the bills you get can be helpful, because sometimes there will be errors that you need to advocate for yourself around, whether it be that balance billing issue we talked about, or just them mischarging you because they got your insurance information wrong. That happens all the time. And so if you're not paying attention and you're just like paying the bill because you don't understand it, sometimes that can lead to, endless costs and things that you just don't understand. So
Okay. Thank you very much for coming on.